I'll start off now. And the topic we are going to discuss today is anticoagulation in atrial fibrillation. So, atrial fibrillation, why is it so important? It is the most important and the most common sustained clinical arrhythmia. So, when we talk about all arrhythmias, whether bradycardias or tachycardias, the most common sustained arrhythmia is atrial fibrillation. So, whereas you would have heard of many things like SVT or supraventricular tachycardia, ventricular tachycardia, VPCs, or uh, atrial flutter, by far the commonest arrhythmia is atrial fibrillation. Uh, and this, of course, is the case after excluding bradyarrhythmias also, because even atrial fibrillation is more common than any sustained bradyarrhythmia also. So it is by far the most common sustained arrhythmia. So how common is it? The prevalence of atrial fibrillation is shown in this chart. This was published a couple of decades back in JAMA, and it shows that atrial fibrillation becomes increasingly common with age. As you can see here, in individuals who are below the age of 60, the risk of being in atrial fibrillation is less than 1%. On the other hand, the risk keeps on rising with age. And by the time one is 80, the risk of atrial fibrillation is 10% or more. So, just as age keeps on rising and you get other degenerative disorders, atrial fibrillation also becomes more common with age. And 10% or more of the individuals above the age of 80 are actually in chronic atrial fibrillation. But please note that at every age, men surpass women in the prevalence of atrial fibrillation. So, how likely is a person to get atrial fibrillation? Uh, it is pretty common. So, if we look at men and women of the age of 40 years, so if they are presently not in atrial fibrillation, the risk that they will have atrial fibrillation at some time in their life is 1 in 4. So that means 25% of individuals of the age of 40 or more are going to develop atrial fibrillation at some times in their lives. So this is a fairly common arrhythmia. So atrial fibrillation management, as you know, revolves around three issues. The first is, of course, rate control and symptomatic management. The second is rhythm control or prevention of recurrences. And the third is anticoagulation or prevention of stroke and systemic embolism. And this is going to be the focus of today's meeting. Why is this? That is because one, of course, atrial fibrillation is a very vast topic, and it is not possible to cover all aspects of atrial fibrillation management in one presentation. But the most important thing is that the worst thing about AF is not AF, it is ischemic stroke. So, ischemic stroke is very commonly associated with atrial fibrillation. In fact, valvular atrial fibrillation increases the risk of ischemic stroke by 17%, whereas non-valvular AF increases the risk of stroke by about 5 times. Furthermore, it is very important to note that risk of stroke is assessed by risk factors, by the CHADS2 score or the CHADS-VASc score, and it is not determined by whether the patient has got paroxysmal atrial fibrillation, sustained atrial fibrillation, or chronic atrial fibrillation. As you know, based on duration of atrial fibrillation, it is divided into three: paroxysmal, persistent, and permanent or chronic. So, the risk of thromboembolism does not depend upon whether AF occurs sometimes or is the patient is all the time in atrial fibrillation. The risk of stroke depends upon the associated comorbidities, which is determined by these two scores. Earlier, of course, we used to use CHAD score. Now we use more often the CHADS-VASc score, and I'll come to that. So if there is low CHADS-VASc score, then whether AF is permanent or paroxysmal, the risk of getting stroke is low. On the other hand, if the patient is at high risk of stroke due to high CHADS-VASc score, then risk of stroke is high. So it doesn't depend upon whether the patient is presently in AF or not. I find this commonly that people tend to think that somebody who comes to them with a history of AF but not in AF at the moment, they they are less likely to prescribe anticoagulants in them. But this is wrong, and risk of stroke is determined by Chad's-Vask and not by the permanence of the atrial fibrillation. So AF, as I told you, is the most common arrhythmia. And globally, of the 15 million strokes which occur per year, AF is responsible for nearly one-fifth of them. And in fact, the risk of stroke being due to AF keeps on rising with age. So between the age of 50 and 60, the likelihood that stroke is due to AF is about 1.5%. This is old studies. But if the patient is more than 80 years old, the likelihood that a stroke is due to AF is almost 25%. This is the Toast classification of acute ischemic stroke subtypes, where we note that 20% of all ischemic strokes are cardioembolic stroke or related to atrial fibrillation. Whereas, of course, others are large artery atherosclerotic, lacunar, rare conditions, cryptogenic. Please remember that this 25% cryptogenic is also contributed to in large part by atrial fibrillation. In fact, there was a study which was published some time back that if we take all cryptogenic strokes, uh, especially young cryptogenic strokes, and we give them what are known as implantable loop recorders. These are pacemaker type of devices, only smaller, and they can be implanted on the chest wall just below the skin. No lead is there. They sense the ECG from the chest wall, and if you implant such a device which can monitor the rhythm in a patient for up to 2 to 3 years, it was found that nearly 30% of these cryptogenic strokes were actually due to atrial fibrillation. These patients had paroxysmal atrial fibrillation. So maybe you can consider that 7 to 10% of these patients would be added here. So the net burden of atrial fibrillation for ischemic stroke would actually be 25% or somewhat even higher than that. So, if we look at all the risk factors for stroke, AF is by far the most common. So, even though high blood pressure is considered to be the most important risk factor for stroke, what we find is that high blood pressure increases the risk of stroke by about 3.5 times. On the other hand, non-valvular AF increases the risk of stroke by nearly 5 times, which is more than any other cardiovascular risk factor. Furthermore, if a patient with stroke is in atrial fibrillation, the risk of death is much higher. The risk of death is nearly double if a patient is in AF along at the time of stroke compared to if a patient is in sinus rhythm at the time of stroke, which means that AF tends to lead to larger strokes with worse prognosis. So, what are the predictors of high risk? The highest risk of stroke is, of course, in valvular atrial fibrillation. Valvular AF increases the risk of stroke by nearly 17 times. Of these, the two highest risk conditions are prosthetic valve, like mitral and aortic mechanical prosthetic valves, and rheumatic mitral valve disease, especially mitral stenosis. Non-valvular AF also increases the risk of stroke by 5 times, and it is especially high in those who've previously suffered stroke or TIA, in patients with advancing age, and in those who have multiple comorbidities, which are reflected by the Chad's-Vask score, which we'll discuss subsequently. However, we must remember that worldwide, every 2 seconds, someone has a stroke. Every 5 seconds, someone dies from a stroke, but nearly 80% of all strokes are preventable, and 64% of strokes due to atrial fibrillation are preventable if we have good control of blood pressure and effective anticoagulation on board. So, how to determine the risk of stroke? So, these are the two most important charts for atrial fibrillation management. One is the Chadsworth score. This is the score with which we determine the risk of getting a stroke. The other is the Has-Bled score. This is the score which tells us what is the risk of bleeding in this patient if he or she is put on anticoagulation. So, as you can see, one score is given for congestive heart failure or LV dysfunction, hypertension, diabetes, previous vascular disease like MI, peripheral arterial disease, age more than 65, and female gender. 2 points are given for age more than 75 and previous history of stroke, TIA, or thromboembolism. So, total this becomes a 9-point score. Has-Bled is also a 9-point score and it receives points for hypertension, abnormal liver or renal function, previous stroke, bleeding tendency, labile INRs, which means INRs aren't stable, they are sometimes very high, sometimes very low, age more than 65, and concomitant drug therapy, which increases the likelihood of bleeding, like aspirin, non-steroidal anti-inflammatory drugs, or alcohol. So if we look at the Chadsworth score, we find that as the score keeps on rising, you can see here the annual risk of getting a stroke also keeps on rising. So this is a finer adjustment in comparison to Chad's score, which is what we had earlier, where even with a Chad score of 0, the risk of stroke wasn't 0. The risk of stroke was nearly 2%. So even though there was a gradation from 0 to 6, but the important point was that even Chad 0 did not mean a genuinely low risk patient. These patients would still get stroke about 2% per year. On the other hand, when we look at the Chadsworth score, we find that it has refined this. The risk of stroke is close to 0 if the Chadsworth score is 0. So if we, apart from these 5 points, which were congestive heart failure, hypertension, age more than 75, diabetes, and previous history of stroke, when we add three other things, that means age more than 65, female gender, and previous history of vascular disease, when we add these 3 points, we find that this refines the stroke rate further. And therefore, if somebody has a Chadsworth of 0, then the risk of getting a stroke is genuinely low. And therefore, one can, genuinely tell these patients that they need not be on anticoagulation and they can just continue on rate or rhythm control depending upon whatever is the plan. This is another data subset that was an older study. This is a newer study, and these group of investigators found that the risk of getting stroke is higher than in the previous stroke. As you saw here, 0 coincided with 0 stroke rate, 9 coincided with 15 stroke rate. Here we find 0 coincides with about 0.78. 9 means around 23% risk of stroke. So basically, if Chadsworth is 0, the stroke rate is probably not 0, but it is close to 0. On the other hand, as Chadsworth score rises from 2 and beyond, you find there is a exponential rise in stroke risk. Anyways, so the first drug which was approved for atrial fibrillation to prevent stroke was warfarin. It lowered the risk of stroke by 67%, reduced mortality by 26%, and this was on large trials, more than 28,000 patients. On the basis of this, it was recommended that warfarin be the drug of choice for patients with atrial fibrillation who were at high risk of getting stroke. Today, the anticoagulation guidelines are something like this, that vitamin K antagonists are recommended for valvular AF, which means patients with prosthetic mitral valve, patients with prosthetic aortic valve or DVR, as well as rheumatic mitral stenosis. On the other hand, NOACs can be used to manage patients who have non-valvular atrial fibrillation. So, what is the problem with warfarin? Why are we talking of newer anticoagulants at all? If warfarin, as we saw in the earlier slide, is so effective at preventing stroke and reduces mortality, why think of another drug? Why are we not happy with it? So, there are many reasons for that. One is that it has got a very narrow therapeutic range. The therapeutic range is an INR of 2 to 3. So, just as the INR starts falling below 1.9, stroke risk rises steeply. At the same time, just as the INR starts rising beyond 3, we found that the risk of intracerebral bleed and all bleeds rises very rapidly. So there is a very narrow window where we have the combination of efficacy as well as safety. And that is why this INR of 2 to 3 is the required INR, and anybody who's in clinical practice knows that this is notoriously difficult to maintain. INRs tend to get disturbed at the slightest thing. Somebody takes another tablet, somebody takes a non-steroidal anti-inflammatory drug, somebody takes a steroid, somebody takes an antibiotic, even fever, everything, and so many things in the diet, especially for instance green leafy vegetables. In Punjab, for instance, where I live, saag is very commonly consumed in winters. So all these things can suddenly change the INR completely in a day or two, and a patient from therapeutic INR may suddenly go into very low INR or very high INR and be at risk of either stroke or bleeding. As you can see, just as INR fall, the risk of stroke doubles at INR 1.7, 3 times at 1.5, 7 times at 1.3. And just as INR rises from 3 to 4, the risk of bleeding doubles. Furthermore, because of this problem and because of the fact that INR needs to be managed very carefully, and INR, which is a blood test, needs to be done very regularly, it is found that warfarin was underused. This is 20-year-old data, 1999, but only 55% of individuals were actually getting VKA even when it was indicated. In fact, in those who were at highest risk, the very elderly over the age of 80 or 85, they were the ones who were getting it the least because of the bleeding risk. And they were actually having the highest Chadsworth score. As you know, age more than 75 gives a Chadsworth score of 2. So they had the highest stroke risk. But since they were also at high bleeding risk, they were the ones who were prescribed warfarin the least. Furthermore, we find that in India, the outcome was even worse. If we look at total Asia, about 40% of individuals who had vitamin K antagonist indicated were getting the drug. In India, of all those who needed this drug, only 38% were getting vitamin K antagonists. Furthermore, because of difficult access to investigation, time which was spent in the therapeutic range was very low. As you all know, this is the time for which the INR is between 2 and 3. And guidelines recommend that the INR should be in the therapeutic range, that means 2 to 3, at least 65% of the time. That means 65% or more. But if you look at these countries, all these countries are either the Western countries, United States, European countries. India comes at 49%. The only Asian country to come here is Singapore, which also comes in the 65 plus percent TTR level. We had abysmally low levels of time spent in therapeutic range, which is why the efficacy was poor. So it is noted in studies that maintaining INR in Asians is a problem, and bleeding rates are therefore higher on warfarin in Asians versus non-Asians. So whether we look at any sort of bleed, major bleeding, GI bleeding, intracranial bleeding, they are all more common in Asians than in non-Asians. And finally, because of a variety of reasons, warfarin discontinuation is near very high. So, over 50% of patients don't take warfarin for more than 2 years. And as you know, with age, the Chadsworth score actually increases. So, stroke risk actually increases. However, we find that with age, the people who go off acetylene or warfarin are pretty high, which is why novel antithrombotic agents were developed. So these agents are divided into two main types. One are the direct thrombin inhibitors like dabigatran. The other are the direct factor 10A inhibitors. These include apixaban, rivaroxaban, edoxaban, and betrixaban, of whom two are available in India, apixaban and rivaroxaban. These two aren't available in India, though edoxaban is also approved in the West. Dabigatran, of course, was the first NOAC to come into the Indian market, and it is the oldest of the NOACs that we have available with us. So, if we look at the results of the studies which compared these NOACs with warfarin, we have four major trials: Rely with dabigatran, Rocket AF with rivaroxaban, Aristotle with apixaban, and Engage AF with edoxaban. So, if we look at the risk of stroke or systemic embolism, we find that this risk is significantly lower in the NOAC group compared to warfarin group. So, there was a 19% lower risk of stroke or systemic embolism in the patients who were put on NOAC compared to the patients who were put on warfarin. And this is large data, this is more than 58,000 patients. Furthermore, if we look at the risk of major bleeding, we find again that the risk of major bleeding was 14% lower in the NOAC group compared to the warfarin group. That means this better efficacy was not at the cost of increased bleeding risk. Generally, bleeding was lower with NOACs. The only exception here is rivaroxaban, which had about the same bleeding risk as warfarin, but this was probably because rivaroxaban had the highest risk patients, whereas Rely and Aristotle had CHAD score of 2.1, 2.2. Rivaroxaban trial had the highest risk patients. They took patients whose CHAD score was 3.5 and whose Hasbled score was the highest. That's why they had more excess bleeds. So if we look at all cause mortality in these four trials, we find that though only apixaban and dabigatran 150 mg reached statistical significance, if we look at the total data, we find that there is a 10% survival benefit in all cause mortality if we look at all the pooled trials. So this is all the four pooled trials. We find ischemic stroke risk, borderline reduction, myocardial infarction about the same, but there is significantly lower, more than 50% lower risk of hemorrhagic strokes, which is associated with a lower all cause mortality, a 10% reduction in all cause mortality. And this is largely because of this safety, lower risk of intracerebral hemorrhage. There was a higher risk of GI bleed, and this is the case with two of the agents, with the rivaroxaban and with the dabigatran. There is full dose dabigatran 150 BD. There is a slightly increased risk of GI bleed in comparison to warfarin, which is not seen with apixaban, but intracerebral hemorrhage is uniformly low with all three agents, and that's why survival benefit is noted with these. Furthermore, adherence is better with NOACs. As you can see, if we look at number of missed doses, they are more with warfarin than with the NOACs, and of these, by far the best is with rivaroxaban because it is the only NOAC with single daily dose. Warfarin also has single daily dose, but rivaroxaban also has single daily dose. Dabigatran and apixaban have twice daily dosing, and that's why adherence is less good with these agents in comparison to rivaroxaban. So finally, what are the current oral anticoagulation guidelines? Oral anticoagulation therapy is recommended to prevent thromboembolism in all male patients with AF and a Church-West score of 2 or more, in all female patients with AF and a Church-West score of 3 or more. And these have the strongest level of evidence, class 1, level A, because it is based on multiple randomized controlled trials. Furthermore, oral anticoagulation, when it's initiated in a patient with atrial fibrillation who is eligible for a NOAC, that means he does not have rheumatic mitral stenosis or a prosthetic valve, a NOAC is preferred above a vitamin K antagonist. This is also class 1A. So, this is to be remembered. So, when the patient has coronary artery disease, especially if the patient has had an acute coronary syndrome, there was a time when we used to use triple therapy, vitamin K antagonist, Disprin, and clopidogrel, but this was associated with a lot of bleeding risk. Because in the first year after an ACS, triple therapy used to be recommended. After that, it was dual therapy with vitamin K antagonist and Disprin. But now dual therapy is recommended after the first 1 week of PCI. So you can use vitamin K antagonist and clopidogrel or NOAC plus clopidogrel, and the treatment of choice these days is NOAC plus clopidogrel for 1 year, and after 1 year using NOAC alone or VKA alone. So this is just a more detailed chart of this. I'll not be going into the details of this because this is probably out of your purview. But what we do these days is that immediately after a patient has had an ACS, we assess the patient for bleeding risk. If the bleeding risk is low, we give triple therapy for some time and then go on to dual therapy. If the bleeding risk is high, we give triple therapy for only a week, then go on to dual therapy, which means NOAC plus clopidogrel. After 12 months, we give oral anticoagulant monotherapy. And this is usually today NOAC rather than vitamin K antagonist. This is elective PCI. I think I'll go on. Anyway, the next important situation which you have to remember is those patients who get acute ischemic stroke when they are on NOACs. So if a patient develops a stroke while he or she is in NOAC, then what we need to do is we need to check how regularly the patient has been taking NOAC. If the patient has missed NOAC for 48 hours, then there is no problem in proceeding with thrombolytic therapy. If, on the other hand, the patient claims that he or she has been regularly taking NOAC, then we have the choice of measuring either the NOAC plasma level or the thrombin time. And if thrombin time is less than 1.5 times, then we can of normal, then we can consider thrombolytic therapy. Furthermore, if we have a NOAC antidote available, in India we have an antidote to dabigatran available, we can consider thrombolysis in these patients. If on the other hand the patient is on vitamin K antagonist, we have to look at the INR levels. Therapeutic INR levels, as we discussed earlier, are 2 to 3. If the INR is less than 1.7, this patient can be given thrombolytic therapy. If the INR is more than 1.7, then thrombolytic therapy is contraindicated due to high risk of bleeding. So, I think I'll miss this. Anyway, so how to and when to reinitiate anticoagulation after a stroke? So this is very important. In a patient who's had ischemic stroke, we divide these patients into 4 subgroups and reinitiate therapy using a scale of 1, 3, 6, 12. That means if the patient has had a TIA, we consider restarting a NOAC after 1 day of stroke onset. If the patient has mild neurological deficit, we consider restarting after 3 days. If the patient has a moderate stroke, then after 6 to 7 days. And if a severe neurological deficit, then 12 to 14 days or 2 weeks is the time that we like to give before restarting a NOAC. Typically, in patients who come with acute stroke after their initial CT, neurologists tend to get a repeat CT after 48 hours or so to determine the exact size of the infarct. And then, depending upon the size of the infarct, they reinitiate anticoagulation therapy, because all anticoagulation is contraindicated for at least 48 to 72 hours, even after a mild stroke. After TIA, of course, one can restart NOAC early. In patients who develop an intracranial hemorrhage while on anticoagulation, it is important to consider what were the factors because of which the patient might have bled, and what were the stroke risk factors. And a re-evaluation is recommended. And in general, what is done is that at least for 4 to 8 weeks, no anticoagulation is given, except in patients who have a prosthetic valve. So, if there is no prosthetic valve, typically one waits for 4 to 8 weeks, repeats a CT, reassesses Chadwick score and Hasbled score, and if it is thought that there is strong indication for initiating anticoagulation, only then NOACs are restarted. On the other hand, if it is thought that the risk of bleeding is too high, then we can consider no anticoagulation and use a LA occlusion device, which is an occlusion device which occludes the left atrial appendage. And what we see is that most patients with atrial fibrillation develop clots in the left atrial appendage. So, if that is blocked, the risk of stroke goes down, and therefore, in these patients, we can use LA appendage occlusion if the risk of bleeding is too high. So, what to do in case a patient develops OAC bleed? We can use specific reversal agents like vitamin K. There is a specific agent available for dabigatran also called idarucizumab. And of course, fresh frozen plasma and clotting concentrates, recombinant factor 7A, RBCs, if required, can all be given. And these agents can be given to control the bleeding according to the amount of bleeding, the site of bleeding, and other risk factor, life-threatening risk factors. So I'll not go into details of this, but for mild bleeding, just local pressure, if it's a site which can be pressed, is useful, and missing a dose. If it is major bleeding, then of course we have to use all these other factors which I was mentioning for reversing the bleed. So finally, coming to the summary slides, current recommendations are that for preventing strokes in atrial fibrillation, if a patient has mechanical heart valve or rheumatic mitral stenosis, we give the patient vitamin K antagonist. If not, and a patient is in AF, we look at Chadwick score. If the score is 0, we give no therapy. If the score is 1 in males or 2 in females, we can consider oral anticoagulant, because risk of stroke is not 0, but risk of stroke is offset by risk of bleeding. So we may or may not give oral anticoagulation in a Chadwick score of 1 to 2. But once score is more than 2 in males and more than 3 in females, then the risk of stroke is more than 5% per year, and we need to give these patients anticoagulation. If the patient is at very high bleeding risk or gets a bleed on anticoagulation, we can consider a LA occlusion device. So this is the summary regarding stroke prevention. In comparison to vitamin K antagonists, NOACs are significantly safer, especially as regards risk of intracerebral hemorrhage. They are at least as effective. They are much more convenient because no regular monitoring is required. And these benefits are maintained both in the elderly and CKD patients, and therefore NOACs will have survival benefits in some settings. Further, in patients who are in atrial fibrillation and get an ACS or need PCI, a combination of NOAC with clopidogrel is the safest combination for 1 year, and after that, just a NOAC alone or VK alone can be continued long term. Who are the optimal candidates for warfarin? These are patients with prosthetic valves or rheumatic mitral valve disease who have renal insufficiency, especially if it is severe. who are taking a stable dose of warfarin and don't find testing INR repeatedly burdensome, especially if they have access to a self-testing machine. And INR self-testing machines are available at home, just like glucometers, and who are concerned about the lack of a reversal agent, which is not the case any longer. Now, dabigatran has a reversal agent which is available. Who are optimal candidates for NOACs? Those who don't have rheumatic MS or prosthetic valves, those who find repeated testing burdensome, those who have labile INRs, who can afford NOACs, and who have normal or near normal renal function. Finally, which NOAC should be used for what agent? The factors to be considered are age, renal function, bleeding risk, prior stroke or MI, drug interactions, etc. So what we find is dabigatran 150 BD is the strongest agent for preventing acute ischemic stroke. Rivaroxaban has the maximum data in patients who have recovered from previous stroke. Furthermore, it has the advantage of single daily dose. Apixaban is the safest agent. It has the least likelihood of causing a bleed, which is why its survival benefit was most significant. Edoxaban as being the safest agent with the least likelihood of bleeding. So, if we look at individual indications, for Asian patients, all agents are okay. In elderly patients, the best data is with low dose apixaban or edoxaban. In renal failure patients, the best data is with apixaban because rivaroxaban and dabigatran are contraindicated below. Uh, Dabigatran is actually contraindicated below an eGFR of 30. Rivaroxaban can be used in a low dose till 15, as can apixaban. But apixaban appears to be the safest in moderate to severe renal impairment. However, below a GFR of 15, none of the NOACs is approved and warfarin has to be used. Previous GI hemorrhage, one should use in all probability either warfarin or use apixaban low dose. If the bleeding risk is especially high, then apixaban low dose or dabigatran low dose. If recurrent stroke, the best is dabigatran 150 BD. This is the only strategy which is more effective than warfarin. And if the patient wants OD doses, then the preference is again for rivaroxaban or edoxaban. So this summarizes anticoagulation management of atrial fibrillation.